Okay, and I'm going to give the floor over to Dr. Taylor. Thank you for coming.
Thank you so much, Dr. Klaus, and everyone. Wow, this is really amazing. I think this demonstrates your enthusiasm as echoed in our enthusiasm in the neuro-oncology community as we increase options for treatment for our patients. So I first wanted to certainly thank the registry for this opportunity, and particularly Dr. Klaus for the invitation. And for those who are interested in joining the registry, here's a QR code. And I think we'll put that in the chat a little bit later too, sort of linking to the registry. And I think the registry has done a wonderful job of garnering so much research and opportunity for patient advocacy and feedback for what you as the brain tumor community you want to see within research and receive in research. And so just thanks immensely to the Low-Grade Glioma Registry for this opportunity. So we're going to talk a little bit about updates on new treatments for patients with IDH-mutant gliomas. And these are my disclosures. I have, as Dr. Klaus mentioned, received grant funding from Servier as well as served on their advisory board. And then also part of the research community within the registry as well. So for a big picture outline today, these are kind of some of our major topics. And I first think it's important to understand what this IDH mutation is and why it is it's so important and how it is in some ways revolutionized how it is that we see and treat patients with primary brain tumors. And then we'll spend certainly majority of our time talking about these new inhibitors. I think it's beneficial to understand the story of how it is that we've gotten here. So there'll be a little of historical context, and then a little bit more pivoting into some of the practicality about the medication, possible side effects and challenges, and then sort of, kind of where do we go from here as far as next steps. And hopefully everyone's able to keep themselves muted. That would be great. Okay. And as Dr. Klaus mentioned, making sure we have plenty of time for questions at the end. So what is the IDH mutation and why is it so important? So just to kind of take a bit of a step back. So, I think these are very reflective MRI scans. These are all of my patients, all in their 40s, all early in their careers, early in their family planning stages, who presented with a myriad of different symptoms, headaches, seizures. I'm sure this probably resonates with a lot of people on this call. And these all end up being IDH mutant tumors. You can see some of these MRI scans demonstrate areas that surgeons are able to take out a lot of these tumors. And then there's a lot of these tumors that are much more diffuse and much more difficult to remove surgically without harming a significant amount of the healthy brain tissue. And so I think this is a good spread of the challenges of sort of even diagnosing and then again ongoing management of patients with IDH mutant gliomas. So all of these patients had surgery at UCSF. The two on the end ended up having the first two ended up having astrocytomas, and then the latter two oligodendrogliomas, and those are two different variations, both of which or all of which have the IDH mutation. And you can tell on an MRI, it's really difficult to determine one versus the other as far as the molecular subtypes. The way that we've historically thought about classifying these tumors, so our wonderful surgeons, including Dr. Klaus, will take these tumors out, will evaluate them under the microscope. And over the last few decades, the sophistication of being able to name these tumors and label these tumors has really evolved. And so I think as we sort of move in sort of these in-between times from the way we've used to treat these tumors to how we will probably in the future, I think, again, understanding where we started is really important. So in 2007, which was a very long time ago, the World Health Organization, which classifies tumors across all different types of cancers, but including tumors of the central nervous system, used a grading system, a grade of 2 through 4, in order to indicate increased amount of sort of aggressive behavior as we increased the grade of these different tumors. And then looking at them under the microscope and looking for features that suggested that these tumors came from oligodendrocytes or astrocytes. And so as we go from grade 2 to grade 3, we have more abnormal nuclei. As we go to grade 3 and grade 4, we also look at more vascular abnormalities and more necrosis, sort of suggestion of increased growth. But this is very subjective and really limited by the fact that you only have a very small sample sometimes that to look at under the microscope. And a lot of this is very operational dependent. So pathologists, who are the experts to look at things under the microscope, really kind of had to do a lot of guessing and subjective interpretation based on their experience. And then in 2007, there was the identification of this IDH mutation. So we'll talk about the function of IDH a few times throughout the talk, but just to sort of starting to wrap your head around this, IDH stands for isocitrate dehydrogenase. And this isocitrate dehydrogenase is an enzyme that exists in the Krebs cycle or the citric acid cycle, which helps power cells. And there's an IDH variant that lives in the mitochondria, and there's an IDH variant that lives in the cytoplasm. And its normal function is to generate this alpha ketoglutarate, which then goes on to generate amino acids and function to power the cell. And then when you end up having this mutation, instead of the alpha ketoglutarate sort of going into its normal pathway, the alpha ketoglutarate gets transferred into this 2-hydroxyglutarate. And that's something we've now learned over the years is promotes tumor growth. And a couple of other things I think that'll be relevant to this audience. So what's been really helpful about this particular alteration is that we can look for this IDH mutation really easily on a tumor sample very quickly. So this is, the brown here is the staining positive of the mutation. So in all of these tumors, all of these brown cells here are all tumor cells that have that IDH mutation. So it's really very common in pretty much all of the cells. And then this blue that you see are the blood vessels, and the IDH mutation doesn't exist in the blood vessels, so you don't see the brown staining here. So that helps us really understand, move from this subjective, does it look like an astrocytoma, does it look like an oligodendroglioma, to at least having a little bit more kind of black and white, wherever it is that you get this staining done. If it stains brown, then you potentially have the mutation. If it doesn't stain brown, then you don't have the mutation. This does include the most common mutation, which is this IDH-R132H, which is 80% plus of all patients who have that IDH mutation. However, sometimes the other 20% is a variation of other different mutations, including those in IDH2. And all of those maybe require additional sequencing. And so again, why is this important? And so if we thought about the way we were classifying tumors in the past, we were looking at these astrocytomas, either grade 2s or grade 3, even oligoastrocytomas, where it was kind of difficult to tell if it was an oligodendroglioma or astrocytoma. And then glioblastoma, which historically is thought not to have the IDH mutation. And this is a Kaplan-Meier curve, and we're going to look at a couple of these today. This is sort of how oncologists look at the impact of either prognostic factors like this IDH or even treatments, about how patients tend to do over time. So on the x-axis here is time, so all the way out to 15 years. And on the y-axis is percentage of survival. So at time 0, everyone is alive, 100% of people. And then if you broke things down by these different subclasses based on how we historically graded them, it's kind of messy. There's a lot of overlap. Sometimes the blue or the purple overlaps with the green. Sometimes the yellow overlaps with the purple. And I think this is reflective of how it is that we as doctors experience patients who have these different histologies. And old versions of gradings is some people do really well and some people didn't necessarily do as well. And it was very hard to tell based on that subjective information under the microscope. So as we look into integrating then the IDH mutation what we could now see is that patients who had low-grade gliomas with the mutation, so the patients here in purple, and here in blue. So if the mutation existed, those patients seemed to their tumors were better controlled, and things went well for a longer period of time. Versus even if you looked under the microscope and it looked like something lower grade, like a low grade with the wild type or without that IDH mutation, then a lot of those patients really didn't do as well. And maybe we should be thinking about treating them more aggressively. So this just sort of, I think, is a shift in the way we were thinking about these tumors, looking at the subjective information under the microscope based on the limited tissue that the pathologist had to examine, to then more kind of objective, whether this mutation was present, yes or no, and how it is that we may talk to patients about treatment options. And then, of course, as you'll see, it kind of migrate towards more considerations for treatment. So when we think about all of these tumors together, so glioblastomas, I think maybe many on the call are aware, are the most common primary brain tumor primary tumors in the brain. And so this doesn't necessarily include meningiomas and pituitary tumors and some of these other more rare tumors, but sort of intrinsic brain gliomas. Glioblastoma is most common. And as I'll show you, glioblastoma is now, now we know, does not actually include the IDH mutation. So we think that the evolution and how those tumors come to be, and therefore the treatment of those tumors, is really very different than if the IDH mutation is present. And so lower grade gliomas, and mostly what we're focused on today, are the oligodendrogliomas, oligoastrocytomas, and then the diffuse and anaplastic astrocytomas, or grade 2 and 3 astrocytomas, are a pretty small percentage, 5%, 11%. So when you add all those up together, it's barely even like a quarter of the pie. But I think you sort of flip that on its head with how it is that these patients do over time. And I think this is a little bit of a complicated plot, but if you stick with me here, I think you'll get an appreciation for why I'm trying to show you this. So here is annual average age adjusted incidence, that's quite a mouthful, per 100,000 people. So how, in a sense, like how common are these tumors, both with the IDH mutations, as you'll see here on these left 4 panels, and then without the mutation for glioblastoma patients that you'll see here on the right. And the blue bars are male patients, and the purple bars are female patients. And then the y-axis here are different age groups. So how common are these tumors, oligodendrogliomas, anaplastic oligodendrogliomas, which is now we would say grade 2 and grade 3, same for the astrocytomas. So you can see oligodendrogliomas are more common in younger age. Astrocytomas are a little more common with increasing age. Oops, sorry, it's something on here is auto-timed, which I wasn't expecting. And then as you can see across all of the age groups and all of the subtypes, blue is a little higher than purple, which indicates that these are a bit more common in males than females, and we do know that to be true. And then these glioblastomas are much more common. So the y-axis here is much, much higher than it is on the in these left 4 panels, and we flip that on its head, looking at then the survival experience. And so here on the top level are 2-year survival, 5-year, and 10-year survival. And for these patients with these different molecular subtypes, purple actually does a little bit better than blue, regardless of these different subtypes. And then a lot of patients who have oligodendrogliomas and astrocytomas are living much, much longer than glioblastoma. And so what that means, in fact, is that many of these patients who are living every day with a glioma do actually have this IDH mutation, as opposed to not having this IDH mutation. And that's why it's so important to think about how it is we can tailor our treatment and our discussions with patients for having the mutation present versus absent. So here we are in 2025, and what we're using is the 2021 classification of adult gliomas. And so now you've got astrocytomas with this IDH mutation, either grade 2, 3, and 4, or oligodendrogliomas with either grade 2 or 3. And then again, wild type means negative, or means that the mutation isn't present. And that's glioblastoma patients, which we are now automatically qualified as grade 4. So this is sort of the evolution of how it is we've been thinking about honing in on these more similar patient experiences and patient journeys, so we can be more tailored in our approach to how it is we're treating patients. So again, if we go back and think historically, given this sort of walking through and really up until August of this past year, when this new drug was approved, sort of how it is where we were thinking about treating these tumors. So this is an example of a patient who has an IDH-mutant oligodendroglioma. And so if we know that, so the patient has surgery, and I think what's most important is, or what is one of the really important factors here, is that the surgeons are able to take out as much of these tumors as possible. So a gross total resection or a maximum safe resection. So we really want as much of this tumor removed as is possible. And then, of course, doing that in a way that's as safe as possible. And there's a ton of different tools that the neurosurgeons use, and Dr. Klaus is much more experienced in being able to comment about this. But we do know from UCSF and from several other institutions that the more of this tumor that we can remove, we think the better. That also gives us more of a chance to examine all the different corners of the tumor and be sure that we're crafting our treatment response accordingly. So if we have the IDH mutation that we've been able to identify under the microscope, then we're able to further characterize these tumors into oligodendrogliomas. And patients who have oligodendrogliomas also have the presence of this 1p19q co-deletion. This is a rearrangement of chromosomes within the tumor sample itself. And we don't really quite understand what it is this is doing to the cell, but we know that all patients now with oligodendrogliomas need to have both the presence of the IDH mutation and the presence of this co-deletion. And then we'll look under the microscope and say, does it look sort of lower grade, slower growing, or are there components of it that seem like it's faster growing and suggestive of grade 3? So note there's no grade 4 for oligodendrogliomas anymore. If that 1p19q is intact or quote unquote normal, then and the IDH mutation is present, then we have an astrocytoma, and again, grading 2, 3, and now we also include a 4. And so these patients may, under the microscope, look like very aggressive tumors, or they may look like lower grade tumors, but have this particular marker, the CDKN2AB, which is sort of a cell cycle dysregulation. And if this alteration is present, then regardless of how it looks under the microscope, we need to be aggressive in treating this tumor. So I think hopefully one of the things you're coming to appreciate is sort of this evolution of the importance of these mutational analyses. This is done under next generation sequencing. Lots of different local versions of this. I'm sure Boston has its own version. UCSF has its own version. There are other commercial entities, Foundation One, Tempus, Caris. So this sort of takes a little bit of DNA and allows you to really examine, potentially hundreds of different mutations to be as confident as possible in the diagnosis. And then again, if that IDH mutation is not present or is wild type, there's all kinds of low-grade tumors, gangliogliomas, DNETs, all kinds of very low-grade, slow-growing tumors that don't have this IDH mutation. But for these intrinsic gliomas, if there does seem to be fast growth, then the IDH wild type is most suggestive of a glioblastoma. And a lot of these other tumors with very, again, slow growth and good outcomes are often seen in younger individuals, and glioblastoma, as I showed you in that graph, sort of increases incidence over time with age. So with some of these, if the tumor is really well resected by someone like Dr. Klaus, for example, then that gross total resection, or everything that seems to come out under the microscope, sometimes we will just watch these tumors, and maybe some on this call have even had that experience where they're getting MRI scans every couple of months, seeing their either neurologist, neuro-oncologist, neurosurgeon, and getting that follow-up. There are certain subtypes of these tumors, most specifically the oligodendrogliomas, where it does seem that chemotherapy, that these are very chemotherapy sensitive medications. And when I say chemotherapy, I mean either oral or intravenous treatments that are leveraging the fact that these are dividing cells. So not a targeted approach, but more untargeted approach of trying to injure the fact that these cells, their DNA is exposed, and trying to kind of interweave the drug into these dividing cells in order to serve as cell death. And of course, a lot of those chemotherapies can affect other blood counts or in a lot of other side effects. And then most commonly, and still is true, most of the data that we have as it relates to radiation therapy, which also is a different way of injuring dividing cells in combination with chemotherapy. And so across really all of these tumor types, we know that chemotherapy and radiation together seem to be more helpful than just radiation alone. But there are a lot of side effects potentially related to these types of treatments. And again, if patients are living for a very, very long period of time, they can accrue a lot of the side effects of the delayed effects of radiation and even chemotherapy. I think what's also important to remember, even if we go all the way back to that beginning surgery, that maximum safe resection, even if the surgeon is able to get everything out under the that we can see on the MRI scans, I often describe these tumors like weeds in a garden. So you can go out into your backyard, see a big chunk of weeds, pull up those chunk of weeds, which is sort of what the surgeons are doing. But if you look down in the garden really closely, you often see these little weeds that are left behind. And if you try to pull up every single one of those little tiny weeds, all of a sudden you're also pulling up your healthy garden. And so we want to try to balance how much of this is removed, and always knowing that there's going to be some cells that are left behind, and that these treatments here along the bottom are really intended to injure and kill as many of those additional weeds, but in a way that's helping to spare the garden, helping to spare the healthy brain tissue. So I mentioned a little bit about some of the other effects that we've learned about IDH and that 2-hydroxyglutarate, or that production metabolite that results from the IDH mutation. And that is seizures. And I think a lot of patients with IDH mutant tumors present often with seizures. And so it's probably even more on the 80% frequency of how often this is how we identify these tumors in patients. It's more common with the mutation than it is in the glioblastoma. And that, again, that mutation itself may be a risk factor. So there's something about that 2-hydroxyglutarate that actually creates potentially seizures. And there's a lot of research in trying to understand the why there. But I think as I show you some of future data, I think it's important that we're looking at seizures, the effect of seizures, if we're trying to block this mutation and try to decrease that 2-hydroxyglutarate. Preventative anti-epileptic drugs is certainly something that that can be considered often around the time of surgery. I'm sure many of you were on, even if you had never had a seizure, that you were on seizure medication for a period of time just to help provide that additional protection. In general, if there has not been a history of a seizure, most of the guidelines through the American Academy of Neurology and the Society for Neuro-Oncology, and even our international colleagues, suggest that we don't need to be on seizure medication preventatively, even if the mutation is present, or even if the tumor wasn't necessarily all the way removed. And I think many of you probably have had a lot of the side effects and experiences of these anti-epileptic drugs or anti-seizure medications, particularly levetiracetam, or that can definitely have an impact on mood. I think these seizure medications are working on the brain, so they often can kind of result in some kind of slowed thinking and processing, and they can be very tiring as well. And so, fortunately, a lot of these seizure medications don't interact with all of the with a lot of the more chemotherapy or tumor-directed therapies, but that's certainly something that always needs to be discussed, especially if you're a place where you're meeting with an oncologist and meeting with a neurologist at the same time. And I think, again, many here probably have had the experience of these are neurologic consequences of both the tumor and the treatment, other psychiatric illnesses, levels of age and education, prior medical history, fatigue, the seizure medicines I just described, the real estate of where the tumor is located, and a lot of additional environmental influences. These all affect the cognition. And of course, the cognition impacts, getting back to work after surgery, being able to take all of your medications, being able to track all of your appointments, driving. Like, these are all really important key things that I think we've certainly heard from all of our patients who are living with this illness for such a long period of time, that these cognitive outcomes are really really key. And so a lot of common cognitive changes that we see, again, both as the product of the tumor and the treatment: working memory, slower processing, multitasking, difficulty paying attention to things. And then that can also relate with some personality and mood changes. So difficulty with kind of your get up and go, some impulsivity. And then again, I think many on this call are also resonates with them, the commonalities of fatigue and sleep. And so these quality of life measures as a whole are really important as we look at new treatments, as we try to compare different management modalities, that we're not just looking at how long people are living with these tumors, but how they're living with these tumors, and some of these important effects like cognition, mood, personality, seizures, as really key outcomes in clinical research, as well as the MRI scan and how someone's tumor is controlled over time. And then these cognitive so this is an example of cognitive strategies and booklets, both Spanish in the bottom, and these are some QR codes for some of the things that we've developed here at UCSF. And happy to share these later on if need be. So then kind of how have we leveraged understanding what this mutation is in order to be able to target it and actually provide new treatment options for our patients? And so again, this is an example of how I showed this figure before, but this 2-hydroxyglutarate, again, is an oncometabolite that ends up generating tumor growth. And if we can block that mutation, then we potentially can decrease this 2-hydroxyglutarate and potentially even stabilize things like seizures and even stabilize tumor growth. This IDH mutation doesn't just exist in brain tumor patients. It also exists in leukemia and cholangiocarcinoma, which is gallbladder cancer. And those cancers are much more common than these brain tumors. It doesn't necessarily mean that brain tumor patients are at risk of developing leukemia or gallbladder cancer, but just that this IDH pathway aberration is kind of hijacked in multiple different cells throughout the body to generate tumor growth. And so as they started looking at ivosidenib, which was sort of the first kid on the block as far as an inhibitor to this IDH, again, that really common mutation, so the R132H, which stains those cells brown that I showed you a little while ago. This again showed when they started using this drug, which was approved in leukemia, and started using it in brain tumor patients, that with this, again, Kaplan-Meier curve of time on the x-axis and survival on the y-axis, that patients who seemed to have slower growing tumors who had received other types of treatment actually seemed to have a pretty positive impact, or sort of their tumors were better controlled than maybe was expected with other additional surgeries or other chemotherapies. And then this is an example of a waterfall plot along the top. And so here, each individual bar here is a different patient. And then the y-axis here is percent change. So for patients who had enhancing disease, or some patients who had non-enhancing disease, or the dye doesn't leak out, as an example, on their MRI scan, that some of these grew over time, but then below the bar, below zero, is actual shrinkage. So we were seeing that with this ivosidenib, which wasn't really meant to be for brain tumor patients, but when we used it in brain tumor patients, we were actually seeing a reduction in the size of the MRI scans and some of these partial responses, both in enhancing and non-enhancing. And so, these patients who were orange here are the patients who were doing the best survival-wise. Enasidenib is an IDH2 inhibitor that's also used in other cancer types. And then based on all of this encouraging data, and then knowing about 20% of patients don't have this IDH R132H inhibitor, vorasidenib then was developed through a pharmaceutical company that targets both of those different inhibitor or both of those different mutations, and then is engineered to try to get into the brain. So they did a really beautiful study where they took patients who seemed like where we knew they had the IDH mutation and they needed to have a second surgery. And what they did here is either gave different doses of the Vora, either 50 or 10 milligrams, or different doses of the Ivo, 500 or 250 milligrams, and then also a couple of controls. And they gave those patients drug for about a month before they took them to surgery. And then what they could see was they measured actually that 2-hydroxyglutarate, or the impact of blocking the IDH mutation and reducing the amount of 2-hydroxyglutarate in the tumor sample. They were able to measure that, which is pretty exciting. And so they can measure that compared to some of external or historic controls. So a patient like a glioblastoma patient that doesn't have that mutation, doesn't have a whole lot of 2-hydroxyglutarate. And then patients who had had surgery and not received the inhibitor had, of course, high levels of the 2-hydroxyglutarate. And then you could see most notably here with the vorasidenib 50 milligrams that the bar gets much smaller and it gets much closer to not having any 2-hydroxyglutarate. So this was sort of a proof of principle that this drug vorasidenib was getting into the brain, and that it looked like this dose was, quote, the winner, though this wasn't designed to necessarily compare across these three. But there's specifically a reduction in the amount of 2-hydroxyglutarate and a suggestion that this drug may work. And then they, of course, followed that up with the clinical experience. As many of you know, or as all of you know, we really follow. We can't do biopsies all the time and see whether the 2-hydroxyglutarate is decreasing in the tumor sample. We use the MRI, right, as a biomarker. And so for the patients who were receiving the vorasidenib 50 milligrams, which is the dark blue here, again, this is that waterfall plot. So a decrease, and actually a lot of the patients, really notable decrease, so shrinkage of this tumor. And we saw that in the ivosidenib as well. But not necessarily in all of the patients. So some of the patients didn't necessarily respond to this treatment. And then this is a swimmer's plot, which again is a different way of thinking about this so again, time on the x-axis, and then each patient is in their own swimmer's lane, if you will, on the y-axis. With the longer that you're going out, more stability of staying on the drug and a response to the MRI scan. So this is really what motivated the development of the Indigo study, which really was one of the most exciting clinical trials I think that any neuro-oncologist would tell you that they've been involved in the last, honestly, few decades. So they took patients with newly diagnosed IDH-mutant gliomas, and just to kind of help dial things in and be homogeneous as possible, they were all noted to be grade 2. And they were at least a year out from their original surgeries. So a lot of the scar tissue and the MRI changes that we see as a result of surgery had kind of stabilized, but they were no more than 5 years out from their last surgery. So these were patients who, in a lot of ways, would have been under that active surveillance that I mentioned before, that we were just monitoring closely with MRI scans. And then patients were randomized and blinded either to receive the vorasidenib at 40 milligrams or a placebo. And so the doctors didn't know, the patients didn't know, only some computer centralized knew which patients were getting the drug versus the placebo. But all patients were equally followed really, really closely with MRI scans every 3 months or so. And then if the patients were being seen in the clinic and it looked like the MRI was, this is a very dramatic example, but it looked like it was worrisome that the tumor was growing, then the doctors in the clinic would ask the central radiologist, so they had kind of blinded radiologists who were looking at the MRI scans, who didn't know any of these patients or anything along those lines. But this was an international study run during the first 2 years of COVID. And so these patients were getting MRI scans all around the world, and the MRI scans were being sent to a centralized location. And if the central radiologists were also worried that the tumor seemed like it was growing again, then they unblinded the patients. And then the doctor would inform the patient about whether they had been getting vorasidenib, and if they had been, then they needed to move on to new treatment, another surgery, chemo, radiation, etc. Or if they were receiving the placebo, they were given the opportunity to cross over to the vorasidenib. And so the primary outcome was progression-free survival, or essentially stability on the MRI scan. And then the secondary outcome was sort of this time to next intervention, which is when the doctor sort of felt that there was enough change on the MRI to sort of do something different. Of course, we're following overall survival here. And then again, really important, measuring that quality of life, cognition outcomes, and seizure control. And then this is that Kaplan-Meier curve for this. So I think this is really very exciting. So the patients who were receiving the vorasidenib, who were in the red here versus placebo, had tumor control based on the radiologist's perspective of tumor control significantly longer. And this was very highly statistically significant. And this resulted in a 61% reduction of disease progression or death, as measured by this hazard ratio. And then this is also something that we saw when we decided to look at sort of when the treating physician said, okay, looks like this tumor is growing, or it looks like the MRI is stable and we're going to keep the patient on treatment. So when the physician seeing the patient in clinic kind of realized that we needed to do something different. So again, that's not reached. And this data was recently updated at the Society for Neuro-Oncology meeting. So about a 75% reduced risk of needing another treatment, either becoming unblinded and crossing over to the vorasidenib, or needing to go on to something like radiation and chemotherapy. So we're really stabilizing these tumors for a very long period of time. And however it is that we sliced and diced and look at the data based on age, based on gender, based on location, of where the patient was treated, based on location of the tumor itself, time from surgery, all those sorts of things, which whether it was an oligo or an astro, how big the tumor was, all of these really seem to favor that patients with vorasidenib did better. And so I think this was really, this is what led to the FDA approval in August of this past year of vorasidenib as the first, new treatment for these patients in, decades. Some data that hasn't been published yet, but that's sort of been presented in abstract form, is that the vorasidenib does decrease seizures also for patients who were getting drug versus placebo. And then we've also seen a reduction in tumor growth. I can anecdotally tell you, it does seem like it takes time. This is a slow growing tumor. It takes time for these drugs to potentially work. And so the importance of those close MRI scans are really key. So how to take it and what are some of the possible side effects? So, again, this is really incredible. This is very new, really, really exciting. So, what's the flip side? What's the downside? Why aren't we just sort of giving this to all patients kind of immediately? And so just to sort of think about how to take it. So Voranigo was approved at 40 milligrams. It's a daily pill. It comes in 30 pills at a time. One cycle is about 28 days. And then it's daily every day. Doesn't matter with food or without food, but daily every day at a consistent time for, we don't know how long. And so it's an open-ended amount of time that patients are on this drug. I'll talk about some of the side effects, but it does require lab work at least once a month, if not more often, depending on some of the lab abnormalities. And this is not a drug that works for everyone. And this is probably not a drug that's a cure that's going to work forever and get rid of all the tumor. And so we need to make sure that these MRI scans are done frequently and intentionally to look for signs of response, and also to look for signs of growth where we need to move on to new treatments. As far as some of the side effects, so this is all from the New England Journal of Medicine paper that was published in 2023. And so the biggest thing here that we've seen, and I think I've seen it much more commonly than I was expecting, is an increase in liver tests. So I think this is definitely a drug that has an impact on the liver. And it is a drug that can have some interactions with other drugs. And it's also a drug that can have an interaction with tobacco. And so fortunately, what we've seen thus far as it relates to the hepatotoxicity or the effects on the liver is that with patients if we see elevated signs of liver injury, then we either monitor it more closely or potentially, if it reaches a certain threshold, have to hold the medication and then continue to sort of do that really intensive follow-up with lab work. It does all seem reversible, thankfully. So if we do see that the liver sort of recovers, we may re-challenge either at the same dose or potentially even at a lower dose. And for some of the patients in the clinical trial who've needed to have that dose reduction, we still are seeing some response. So it doesn't necessarily mean that less drug isn't going to work, but it definitely has to be balanced with some of those side effects. And then, so if you're ever starting any new medications, be sure that you talk with your doctor about also being on the vorasidenib so that we can make sure that there's no risk or that anything else needs to be followed more closely. And then I think one of the biggest challenges, again, is, I started off this talk talking about my 4 patients who are in their 40s, still planning their families, still sort of developing their careers. And I also just mentioned that this drug is something that's ongoing for an extended amount of time, an open-ended amount of time. It potentially can have an interaction with hormone contraceptive use. And so there can be an interaction with oral contraceptives. So that needs to make sure, and pregnancy testing is a really important part for females of reproductive age. And then this is a drug that we, thus far at least, doesn't look like we're able to allow safe pregnancy in. And so I know I individually have a patient who's sort of gone through the surrogacy program in order to try to conceive a child while also being on this medication because it's working for her. But it may have also longer term effects of fertility that we're all still trying to understand. So even if you stop the medication because it's working or because you need to do something different, we still don't know, right? It's still too early for us to know sort of the long-term effects of fertility on both females and males. And then breastfeeding is also not recommended. So I think this has been a really interesting component of these discussions with patients, of trying to understand how it is that to talk to someone who's still young, has a lot of life to live, and then how to sort of balance their expectations that they have with their life and being on this medication long term versus most of the other treatments that we've used, more traditional chemotherapies, where you would be on it for like a year and then you would come off the medication, and then potentially family planning would ensue. So I think this is a really different change. So the unknowns and the future opportunities. So this was a neuro-oncology practice article that we wrote a couple within the last year. So just a lot of showing kind of what we don't know. I mean, this is really exciting and we're all very, very enthusiastic, but there is still a ton that we don't know. So is there a role for this drug before surgery, for example? Is there a role for this treatment in less than 1 year after surgery? Is there a role for this drug after 5 years of original surgery? What about patients who have grade 3s? What about patients who've received radiation and chemotherapy? And then I think, how long does someone need to be on this medication? Is it something that needs to be on for forever? Is there something that maybe we can give drug holidays and still have good control? So these are really a lot of questions. And does this actually translate into improvement in survival? I think the presumptive answer to that is yes. And certainly we're being able to, the goal is to delay some of those side effects of things like radiation and chemotherapy. But at the same time, we don't actually know that those tumors are going to respond as well to those treatments. And we also don't know that this is going to extend survival for patients. And so, again, a lot to be determined here. There are some additional clinical trials that are using the vorasidenib in combination with other treatments such as immunotherapy. There's some clinical trials in combination with temozolomide. So there's room for improvement here, I think, as we try to continue to improve outcomes and combinations of therapy. And then I think the question for you all, right, is vorasidenib right for you? And I think you have to talk to your, hopefully, neuro-oncologist. I think these do really warrant very multidisciplinary treatments. Again, I showed you how rare this tumor is. And I think as a whole, and I think it does require a multidisciplinary team. Should you do vorasidenib instead of radiation? Should you do vorasidenib instead of a second surgery? Should you do vorasidenib before surgery? So, I think there's a lot of questions, and I think a neuro-oncologist or certainly a multidisciplinary team is really important as part of that. And so just to kind of also plug some of the additional resources we've developed at UCSF, a caregiver program, a cognitive and emotional care, and a survivorship program, just to sort of make sure that the decision to do treatment or the timing of this treatment is one aspect of all of your lives, right? And everything is so much bigger than what's happening within the day of that MRI scan. And so we want to be sure that we're trying to address all of those things. So we do have a young adult brain tumor support peer-led program at UCSF that meets on a monthly basis. And 2 patients here who are UCSF patients lead this group. And then we also have a one-on-one peer support program as well. So, just sort of making sure we're helping to build community, which I think is, a lot of the reasons why everyone's here today. So in summary, I often describe patients who are living with IDH-mutant gliomas are running a marathon. This is a very, very long, potentially a long course, and sort of how do you pace your water stations and pace yourself throughout this journey. And though even it comprises a small percentage of patients with brain tumors, that a large proportion of people living with these illnesses in the United States and around the world actually have these lower grade IDH mutant tumors. So even though it's rare, it's common, if you will. And then advances in how we've defined them have really been very beneficial. These new inhibitors are incredibly exciting, and there's still a lot of information that we don't know, but it's sort of unlocked a key to how it is that we want to think about things going forward, and then making sure that we're also addressing all of the important quality of life measures as well. So just thanks to our amazing team here at UCSF. And then we have this patient resource library that I want to be sure that to call everyone's attention to, that has a lot of sort of just educational material and an opportunity to sort of help kind of build out those communities. So with that, I will end my talk, and I see there's been a lot of questions in the chat. So
I can help you with that, Dr. Taylor. So thank you so much for a wonderful presentation. I am going to, so that people have a little bit of privacy, stop the recording.